Good morning, everyone, and welcome to the Postgraduate lecture series. My name is Annie, and I'm honored to be the student chair of today. I'd like to begin by acknowledging that today we're meeting on the unceded land of the Wurundjeri people of the Kulin Nation. I pay my respects to their elders past, present, and emerging. Sovereignty has never been ceded. It always was and always will be Aboriginal land. The topic of today's lecture is randomized controlled trials in low resources settings, a statistical perspective. It is my pleasure to introduce the speaker, Dr. Rebecca Harding. Rebecca completed her PhD at the University of Otago, where she studied the effects of sleep-disordered breathing in children on academic performance. After moving to Melbourne in 2019 to complete her Masters of Biostatistics, Rebecca joined WEHI in June 2020 and began working as a biostatistician in the Postgraduate lab. Rebecca's research involves around the discipline of biostatistics that underpins the use of statistical methods in the collection, preparation, and analysis of data for clinical studies. Her primary area of interest is in the improvement of maternal and child health outcomes, where she's involved in a program of large randomized controlled trials in rural Bangladesh and Malawi to assess new solutions for anemia control with the goal of improving pregnancy outcomes, maternal well-being, infection risk, and child growth and development. Without further ado, please join me in welcoming Dr. Rebecca Harding to the stage.
Thank you very much for that introduction. And again, thank you everyone for being here today to listen to this and who is tuning in online. I would like to start my presentation today with my acknowledgements. This is to ensure that they both receive the attention they deserve, but also to highlight the collaborative nature of both statistical and clinical trials work. I recognise and thank the efforts of those here locally in Australia, particularly the Postgraduate lab here at WEHI and collaborators at the University of Melbourne. Also thank internationally our collaborators based at TRUE in Malawi and ICDVRB in Bangladesh, along with our colleagues there, definitely the participants and our funders, of which we know that without them we would have no research that I could in particular talk to you about today. So to begin here, the World Health Organization defines clinical trials as any research study that prospectively assigns human participants or groups of humans to one or more health-related intervention to evaluate effects on health outcomes. Typically, one thinks of the intervention as a novel drug, but an intervention can take many forms, such as devices and medical devices or bed nets to reduce malaria and so on. So these interventions are tested to see whether it's effective and safe for its intended purpose, and this is done through a series of human trials known as clinical trials. In modern medicine, the clinical trial is the gold standard and most dominant form of clinical research beyond that of pulling together the evidence in meta-analyses or systematic reviews. One caveat here is that it's important to note that a randomised controlled trial, although considered the gold standard for evidence of a causal effect, is not always appropriate for all research questions. This is because it may not be ethical or feasible to conduct a randomised controlled trial in some settings. For example, we can't allocate some people to smoke and some not to smoke. So in those instances, we'd rely on observational studies, cohort or case control studies. Here at WEHI, in particular in the Postgraduate lab, I'm working with a group who are undertaking a program of these large randomised controlled trials, both rural Bangladesh and Malawi, to assess solutions for anemia control with the goal of improving maternal and child health. And within these trials, lots of sub-studies that also take into account our outcomes of pregnancy outcomes, maternal well-being, infection risk, and child growth and development. To introduce to you today some basics of these statistical concepts and methods, I'll work through a motivating example of a clinical trial that our lab has done that was published in The Lancet last year. This trial is anemia affects around 46% of pregnancies in Africa. And oral iron is often recommended by the WHO, but uptake and adherence to oral iron is often suboptimal. So we've tested a single dose of a modern intravenous IV iron formulation known as ferric carboxymaltose for anemia treatment in Malawian pregnant women. So the revamp trial has participants of Malawian women with a singleton pregnancy in their second trimester. Our intervention is a one-off IV iron infusion, ferric carboxymaltose, compared to the standard of care oral iron tablets that women would take throughout their pregnancy. And that main outcome that we're looking at interpreting is maternal anemia at 36 weeks gestation. And this study was a parallel group, open label, individually randomized controlled trial. So once we've designed our trial, defined our research questions and collected our data, which would be another talk for another day, a statistical analysis of your data is then needed to help you answer your research question and help convey the results hereof. So this talk is more of a practical guide into the essentials of some of our statistical analyses and reporting of our randomized controlled trials. And we'll also touch on some of the statistical controversies that are commonly faced when you're reporting a major RCT. So let's start with some of the essentials of statistical analyses. For this, we will use the framework of the analysis process. So this process consists of collecting data, summarising data, and our statistical inference. So we collect data such as our demographic or primary outcome data for each individual, which we'll classify as our raw data. These observations of the collected data are then summarised using appropriate measures. And this data is then statistically analysed where we compare groups using appropriate measures and make inferences about our target population. So we'll go through each of these in detail in the next few slides. So in step one of the analysis process, we collect our study data, so such as our demographic or primary outcome data. So in the revamp trial, we collected information such as age, education, and income source. We collected some other disease-related information that we thought might help us build the story around our effects. So we looked at some of the HIV status or different inflammation levels at baseline. And we also collect our outcome data. So hemoglobin concentration, which we can therefore derive anemia into our anemia status, yes, no, and other biochemistry data and birth weight in the children. As part of a trial too, it is also recommended that every trial publication summarises study participation throughout the trial. So this diagram here is what we like to put in all our publications, and it tracks the journey or the flow of participants right from being assessed to eligibility into when they're randomised, follow up through the trial, and then those who are included in the analysis set. We also then summarise our main observations. So the first table in any clinical trial report shows patients' baseline characteristics by treatment group. The characteristics to present can vary by trial, but will almost always include your key demographic variables, participants' related medical history, and other variables that we might think are strongly related to our trial endpoints. Of note in these tables, we note categorical variables are shown by a number in percent per group. And for qualitative or continuous variables, we have two main options. This is the mean and standard deviation, or our median and interquartile range, where here our interquartile range represents the spread of the middle half of our data from the 25th percentile to the 75th percentile. The use of p-values in baseline tables should be avoided, especially in RCTs, where our setting, where it's well conducted, any differences at baseline between our two groups must have arisen by chance. The key table that we also use to summarise our observations displays the main outcomes by treatment group. So this is similar to the baseline table where categorical variables are shown by number and percent, and quantitative variables are means and standard deviations, or our medians and interquartile range. So here we're seeing that anemia prevalence at 36 weeks gestation looks to be numerically lower in mothers randomised to the IV iron with 52% prevalence of anemia, compared with the standard of care 57% prevalence. Such a table of our main outcomes will also include estimates of our treatment effects, our 95% confidence interval, and our p-value. This can then allow us to compare the groups and therefore be able to make our inferences about the target population. So to see, okay, is there any differences between groups, we're going to go through our 3 steps of statistical inference. So our first step here is to calculate the estimate or the size of this treatment effect. So looking at the difference between our two treatment groups. Exactly what type of estimate is required depends on the nature of the patient outcome, of the interest. So there's often 3 times the main outcome data. So a time to event outcome, for example, a time to symptom relief, where we'd look at an outcome of a hazard ratio. A quantitative outcome, for example, our change in hemoglobin concentration from randomization to delivery. So we might look at a mean difference there. Or a binary yes-no response. So for example, what we're looking at today are anemia yes-no. So we'll just focus on our binary outcome today. We can also calculate a confidence interval for this treatment effect, which helps us represent the uncertainty in our estimate of our sample, and derive a p-value to test our hypothesis that there's no association between exposure and the outcome in the population. And this can help us represent the strength of evidence against the null hypothesis. So each of these topics, again, will be illustrated in the next few steps. So the collected outcome data from REVAMP can be shown on a 2x2 table here, where the rows represent our 2 treatment groups, our IV iron or our oral iron, and the columns are 2 outcome categories, either anemia, yes or no. So from this table, we can see that in the IV iron, we've got 179 out of 340 participants who have our primary outcome of anemia, and the oral iron with our 189 out of 333, or 57%. So now we're interested in comparing these 2 proportions. So to calculate our treatment effect, here we can look at a prevalence ratio of 0.92. This prevalence ratio allows us to compare the prevalence of our outcome anemia between our 2 treatment groups at our specific point in time. If there is no difference in a prevalence ratio of the outcome between these 2 groups, the ratio would be 1. And then we see if we have a value greater than 1 for this ratio, the higher prevalence would be for the treatment group compared to the comparison group. And then coincidentally, if you have a prevalence ratio of less than 1, this would indicate lower prevalence for the intervention group compared to your comparison group. This prevalence ratio can be converted into a relative reduction in prevalence. We're showing here on the percentage scale that there's an 8% reduction in the prevalence of anemia at 36 weeks gestation in the IV iron compared to our oral iron group. Another important statistic here is the absolute difference in percentages. This is sometimes called the absolute prevalence reduction. So here we see it's 5%. So we can say the proportion of anemia at 36 weeks gestation is 5% lower in the IV iron compared to the oral iron. So in trial reports, it's really useful to present both the relative and the absolute values. So the relative effect expresses in relative terms what the estimated percentages of the primary event of anemia on oral iron would have been prevented by using IV iron instead. So here the prevalence of anemia in the IV iron group is 92% of the prevalence of the oral iron group. The absolute effect is the estimated absolute benefit across all randomised patients in avoiding the primary endpoint of anemia by giving IV iron instead of oral iron. So here in the IV iron group, there's 5% less participants with anemia in that oral iron group. One might think we're done there and we'll say, okay, the relative treatment effect is an 8% reduction in anemia prevalence. That would be the case if our sample was as big as the entire target population. But this is not the case. Instead, our sample here is just a random subset of the target population, and the question is whether we can consider this treatment effect estimate as representative of our target population. So because we're interested in this population prevalence ratio, we can estimate this using the sample prevalence ratio. So this is then we can use this to measure the precision of this estimate by computing our confidence interval around our sample prevalence ratio for this population prevalence ratio. So this is what you might see termed or discussed as our statistical inference, where it's the process of making statements about the population from the results of our sample. So this is where we can dive a little bit deeper into confidence intervals. So I'm not going to go too much today into the actual definition or the formula for calculating these. Just to note that the confidence interval represents the uncertainty in the estimate of the treatment effect. So it provides a range of values for which we believe that the true population parameter is likely to fall. So our lower limit of our confidence interval is the lowest plausible value for the population parameter of interest. It indicates the lower boundary of our confidence interval, and it suggests that the true value of the parameter is likely to be higher than this limit. Our proportion in this instance represents the sample estimate of our population parameter. It serves as our best guess for the true population parameter based on our sample data. And then we have our upper limit of the confidence interval, which is conversely representing that highest plausible value for our population parameter. It indicates that the true value of our parameter is likely to be lower than this limit. So commonly we use our 95% confidence interval. So we say we're reasonably confident that the range of values between the lower and upper limit are the true population value. Just one thing to note as well with confidence intervals, that they don't always have to be symmetric. So your proportion may not always be directly in the middle of your upper and lower. We're just saying that this is our best guess for the population parameter based on our sample, and it could actually fall anywhere between the lower limit and the upper limit of this confidence interval. So another way to say this or talk about confidence intervals is, imagine we had the luxury of repeating our sample 100 times. If we were to draw several independent random samples of equal size from the population and calculate 95% confidence intervals, all 100 sample differences in the proportions would vary around that true what we deemed population parameter. And then on average, 95 out of 100 such confidence intervals would contain the true population parameter, and 5 of every 100, so in the red here, would not contain. So this is when we say with our confidence intervals, we're 95% confident, and we're reasonably confident that this range includes the true population value. So in our motivating example, the observed relative risk reduction here was 8%, and our 95% confidence interval ranged from between -6 to 20%. So what does this mean? In simple terms, we're 95% sure that the true reduction of anemia prevalence at 36 weeks gestation lies between -6 and 20%. We note here that this 95% confidence interval includes the null value of 1 for a ratio, representing no relative difference in these proportions between IV iron and oral iron. So then in statistical inference, alongside our confidence interval, this p-value can also play a pivotal role in hypothesis testing, where it's used to determine the evidence against the null hypothesis. So our null hypothesis reflects that there's no effect, and the p-value quantifies this evidence. So it's the probability of observing a result as extreme or more extreme as the observed result if our null hypothesis were true. So in other words, how likely it is that our result may have occurred by chance alone. Now, we don't think of p-values as a black or white, significant, not significant dichotomy, but we should sort of think of them as a continuum of evidence, where the smaller the p-value, the stronger our evidence is against our null hypothesis. That is, the more convincing the evidence is that a genuine treatment difference does exist. So in the revamp trial, our prevalence ratio between the IV iron and the standard of care in anemia pre-delivery was 0.92, which we know indicates an 8% decrease in the prevalence of anemia in women receiving IV iron compared to standard of care. Remembering our confidence interval range from -6 to 20%, which is spanning the null value of 1. So under this null hypothesis, there's no difference between IV iron and oral iron. That is, the observed magnitude of treatment difference has more than a 5 in 100 chance of occurring. So as we have weak evidence against the null, or a larger p-value, it's customary to declare that there is insufficient evidence that IV iron reduces anemia prevalence. But this should not be interpreted dogmatically, as in that it has no effect, that the null hypothesis is not necessarily true. We should declare that there's actually insufficient evidence that IV iron lowers anemia prevalence compared with standard of care. It may be that the IV iron has a modest effect, or it may be that it has no effect. Our data in this case are inconclusive. A common quote that's out there is that a p-value, however, is no substitute for a brain. This quote reminds us that the interpretation of a trial result rests on more than just a significant p-value. It's good practice to always state what that actual p-value was and not just say it was above or below a magical threshold, and also helpful for us to recognise the link between the p-value and the 95% confidence interval for the treatment difference, and if it is or is not including the null value. So a small p-value can clarify that observed treatment difference appears greater than what could be attributed to chance, but it does not automatically mean that a real treatment effect is occurring. Of note also with our statistical significance, if we look at it, there's an important distinction between what we might class as statistically significant and of clinical significance or clinical relevance in our treatment effect. So our statistical significance indicates that the likelihood the observed results are not due to chance. Whereas clinical significance, it's this magnitude of the treatment effect. And the confidence interval is a guide to whether the benefit of the new treatment is sufficiently great that we could use or merit its use in clinical practice. Now, there are many statistical programming tools out there, and I haven't gone into much depth of how I've used them and what I've done today. Many of these will just automatically help us print out our treatment effect, our confidence interval, and our p-value. So the main one that I use in my everyday today is Stata with R, and a lot of group with their wet lab studies and stuff also use Prism. Now, this is not an exhaustive list of programs that are out there, and they all sort of have their strengths and weaknesses of what we're really trying to focus on in the analysis set. I won't cover any of these today, but these are all, I think, very helpful statistical-based tools that we can use. So now we want to tackle a variety of more of these complex statistical challenges that we're often faced with when we're reporting our clinical trials. So I'll just touch on a few of these today, including the multiplicity of data, subgroup analysis, and the analysis by intention to treat. So overall, if we think about the key challenge of reporting of an RCT is to provide a balanced account of the trial's findings, especially if we think about when we're running these trials, the large number of variables of data that we collect. So Revamp alone has over 2 million individual data points if we take into account all our questionnaires and samples and all of our women randomised at multiple time points. So there's a potential chaos of the innumerable tables and figures that could be reduced for the purposes of treatment comparisons. So in the first instance, how do we validly select which to include in the trial publication or our main question that we're trying to answer? So a first step to overcome this is having a predefined statistical analysis plan that becomes fully signed off, database looking, and study unblinding. So this statistical analysis plan, alongside with the protocol and trial registration, is critical for us to ensure appropriate reporting of trials. And this document is a standalone document. This statistical analysis plan, they should always be made publicly available. So they're typically always included as a supplementary file in the main analysis paper and published as a separate shorter document before database log. So the SOP is prepared by the trial statisticians and it's approved by the trial executive, so the PIs and CIs working on the trial, all of whom at the point must be blind to any interim results by treatment group, or they must not know anything from the outcome of the trials. So a good statistical analysis plan doesn't only document exactly which analysis is to be done, but it also elucidates to the relevant priorities in their interpretation, especially regarding the primary hypotheses, secondary hypotheses, and any predefined safety concerns. And mention of any exploratory analyses like our subgroups, which may be more hypothesis generating in spirit. There are existing guidance documents on the content of statistical protocols, so like writing a spirit statement, and also of the reporting of trials. So you may have heard of the consort statement before, which is the consolidated standards for reporting of trials. These are a well-established set of guidelines, which to us, many of the journals expect our authors to adhere. Now, although this protocol guidance documents and trial documents refer to some of our statistical analysis, there is no actual formal guidance on the content of the statistical analysis plans, which can lead to much variation in practice. However, there was a 2007 paper in JAMA that's attempted to help with this by aiming to develop recommendations for a minimum set of items that should be included in statistical analysis plans for clinical trials. And this is developed with input from statisticians, previous guideline authors, journal editors, regulators, and funders. So all of these guidelines are helpful. We're not only when we're just writing or working on trials, but also if you've been reading a lot of trials and you want to see what's included and how good these trial reports may be, they're very helpful guidelines that we can always refer back to. So just shifting focus slightly here again, another element of our multiplicity that we need to consider is the possibility of our multiplicity of data. So as part of our clinical trial, we perform many statistical tests. So we've got multiple outcomes, multiple time points, and multiple subgroups. And this can produce a lot of p-values that we need to interpret. So this can lead to an inflation of our type 1 error. So our type 1 error is the classical example of telling a man he is pregnant when he is not. This type 1 error occurs when we conclude that the drug is effective, or we reject the null hypothesis in our study, when actually it would be true in the population. So this is what we classify as our false positive. So the probability of at least one false positive conclusion increases with our number of statistical tests. So for example, if we're testing 10 individual hypotheses, the probability of at least one type error rate can be as high as 40%. So this increase in false positive findings is a potential concern because we can't really tell which tests are correctly or wrongly rejected. So we need to avoid falsely concluding our trial is a success when it is not. So in the revamp trial, ways that we've done this is initially we've selected a one treatment comparison with one primary endpoint at only one time point and presented the p-value as is, so standalone with no adjustment for multiplicity. There's typically some multiplicity that does still remain in our secondary outcomes or our additional time points. So we can address this by adjusting our p-values for multiple testing to control for too many false positive findings. And for our other secondary outcomes and time points, we present the estimate and the confidence interval, but no p-values. So this helps us to prevent the interpretation of statistically significant findings that may just be due to chance alone. So note to mention here that adjusting for multiple testing is also very important, not just in trials, but in your genomics and your bioinformatics style analysis, especially when you're dealing with thousands of hypotheses tests, which again will probably be covered in many of the other lectures within this series, so I won't touch today, but some of the commonly used techniques in trials, such as this Bumfor-only correction, are considered too conservative, some of the genomics and bioinformatics, so meaning that they may miss some of these important findings. So I think the take home from this is that multiplicity of data is something that we need to think about and control for, and the way we do that depends on our type of analysis or what we're working with. We also have patients, when we recruit them in a major trial, they're not all the same bunch. So they've got different medical histories, different demographic factors, or different baseline features that can vary. So a subgroup here is a patient-based characteristics, such as age or their history of past smoking. So these subgroup analyses tend to originate from the concern that the response from the average will not apply to everybody. So we can undertake subgroup analyses to see whether the overall result of the trial appears to apply to all eligible patients, or whether there's evidence that the real treatment effect depends on only just certain baseline characteristics. So for example, in Revamp, we had 8 predefined subgroups. We were looking at parity, HIV status, severe anemia status, iron deficient status, iron deficient anemia status, their inflammation status, if there'd been malaria positive before screening, and also the site at which they were screened or randomized from. So our subgroup analysis is this evaluation of the effect within each of the subgroup strata. So for example, the effect with the women who were iron deficient at baseline versus the effect of the women without iron deficiency at baseline. Overall, there's a responsibility for us to perform and present these subgroup findings from randomized controlled trials, but the interpretation of our analysis does present a particular challenge. So the pre-specification of a limited number of intended subgroup analysis is helpful to guard against our post hoc manipulations of the data, or a data sort of dredging, but our interpretations of these analyses are still restricted by a lack of statistical power and a multiplicity hypotheses. So we must note that although these can be hypothesis generating, we need to have due caution and to not overreact or get too excited and make big claims about some of our subgroup findings in the trials. So the kind of figure here called a forest plot is the usual way of documenting the estimated treatment effect within each subgroup together with its 95% confidence interval. So if we scan across the subgroups, one can see that the estimated treatment effects vary by chance and that the confidence intervals tend to be wider for the smaller subgroups. We also see that these confidence intervals overlap this null value line here at 1, so that indicating that this subgroup has no evidence against the null hypothesis. This will inevitably happen, especially in smaller subgroups, and it's not overly helpful in interpreting the subgroup findings. So instead, a statistical test of interaction tends to accompany each subgroup display. So here it's in the last column of our figure. So this concept of an interaction refers to the possibility that the effect of a treatment or intervention differs across different subgroups of the study population. So for an example here in Revamp, we're examining the effect of IV iron on the prevalence of anemia, but we might want to know the effectiveness of this treatment and if it depends on the iron deficiency status of the mother at baseline. So this difference in the effectiveness across the iron deficient status groups would indicate if there was an interaction between the medication of IV iron and their ID status. So this p-value for the interaction helps us determine whether the observed differences in our treatment effects vary across the subgroup data and if these are seen as statistically significant. Another topic that we may have come across, particularly when reading publications of clinical trials, is that of the intention to treat population. So in what follows here, I'll illustrate the difference between the 3 different analysis samples. So assume here that we have a trial that has 2 treatments, control and experimental, and the outcome is a binary outcome. So in reality, there's no difference between the 2 arms, and both have a good outcome, and 75% of the participants are randomized into our trial here. Now assume in the experimental arm that one patient does not follow this experimental treatment as intended, but instead they took the control treatment. So the patient here is non-compliant with the experimental treatment. So let's assume then that this same participant is the one in our experimental group with the bad outcome. So we could exclude the patient from our analysis and analyse our data as per protocol. But as a result, we'd be then comparing 75% of a good outcome with 100% of a good outcome in this analysis. We could also analyse the patient according to what the patient received, or the as treated analysis. But in that case, we'd be comparing our 60% to our 100%. If we analyse the patient according to what they were randomised, regardless of what treatment they actually took, this is our intention to treat analysis. So in this case, both treatment groups have a good outcome in 75% of the participants as randomised in the trial. So our intention to treat principle, therefore, is the effect of a treatment can be best assessed by evaluating on the basis of the planned treatment regimen rather than the actual treatment given. So following this, our intention to treat population refers to all participants in the trial who were randomised to a treatment group, regardless of whether they adhered to the treatment or not, or withdrew for the study. So this allows us to provide a real-world assessment of our treatment effectiveness. So overall, as our journey today, we've noticed there's always uncertainty when we try and estimate population parameters. There'll be an inherent uncertainty in the estimate. So we can use statistical methods to help quantify and convey this uncertainty using our confidence intervals. The p-value to us is not a binary quantity, so we should avoid dichotomizing and saying whether it's below or above a certain threshold, but think of it on our continuous scale and make conclusions whether as the study leads to a biological discovery, and not necessarily in a black or white way, but how strong is our evidence that we've seen. We can also look at the results of our study, not just with the p-value, but taking into account the point estimate, the confidence interval, and looking at it as a whole picture. So our conclusion about the results should be based on information, plus also our broader considerations, including the design of the study, the selection of our participants, controlling for our potential confounding bias, our quality of our measurements, multiplicity of data, and not just the single p-value. So these results, we want to also consider what's been reported about a particular topic using the knowledge and experience of our content experts or what we've seen come before us. And we don't want to just fall for the significant or non-significant in the abstract. So always look at the paper where you can, deciding if you can accept claims made by authors, particularly if there's going to be some clinical or public health significant for your results when making decisions. So a nice short, sweet seminar today. Thank you for walking through this statistical guide, and I'm very happy to take any questions.
Hello. So yeah, if you're in the room and you ask a question, there's chocolate. So yeah, any questions?
Hi, Rebecca. Great talk. I just had a question about the subgroups. So you know how you're saying if maybe like there could be potential for a particular group of the population to have responded better or something. And then about the p-values based on interactions. Yeah. So how do you calculate it? Is it just the p-value of that subgroup or is it like compared to the other groups?
Yeah, so great question with the subgroup. So it's usually we just, get the number spit out of our starter program or whatever. What it's doing is initially we're looking at the treatment effect and the confidence interval in one level of the subgroup. For example, the easiest thing is we think about if we're comparing males and females.
Yeah.
So we compare the effect of our IV iron or whatever our intervention is against our comparison arm in just one level of the subgroup. We then compare what the treatment effect and confidence interval is in the second or multiple levels of that subgroup.
Yeah.
And what this interaction p-value is doing is actually comparing the two treatment effects and confidence intervals within each sub-level to see if there is a difference between the effect of them.
Okay.
Yeah.
Thank you.
Hi, Rebecca. Great talk. You mentioned before that not all trials can be randomized, and I know that that's pretty significant too when doing statistical analyses. How do you correct for that, and what considerations do you take?
So within this, I guess in the trials, we're dealing with studies that actually can be randomised and ethical and feasible to do so. And some of the other study designs then, if we can't randomise, we'll be looking at our case control studies or our, cohorts that we can follow up and take into account, is it going to be prospective or retrospective, or it takes into account some of our different biases. So our cohort study, we often have to take in some of our confounding bias or those differences kind of before the way. In a trial, it's kind of nice in a neat little box. So everything we've seen is the differences are random at the beginning and we're kind of in this well-controlled setting. So there's less that we have to take into account. But if it is something that's not feasible or not ethical, that's when we go back to our design and if we can't design a trial, will we look at a case control? Will we look at a cohort study? Or how can we look at this differently?
Thank you.
Actually, I do have a question. So you mentioned that it's important to take basal measurement and to see whether there's like basal difference in a cohort of clinical trial. Have you ever done any have you ever needed to do some like normalization to your data from a clinical trial?
Yeah, so what we tend to see in our trial is we hope for the best, and often like in Revamp, there was actually no different baseline levels within these, but that's when some of these differences are then we can perform some sort of covariate or adjusted analyses where we go, oh, actually, for example, these women were different in their HIV status at baseline or their age, for example, so we can control for that. So we add that as a confounder or a covariate in our analysis set. We say, well, actually, our treatment effect still appears to hold true, or it just gives us more confidence in the effect that we've seen, regardless of the differences. And then some of these baseline differences as well are actually what forms some of our subgroup analyses. So it's a factor that we know is different pre-randomization, and then we're looking at the effect of that treatment within each subgroup strata. So there are, are we going to covariately adjust for analyses or look at these as a subgroup analysis to take that into account?
Right, thanks. Any other questions?
I'm just joking, Rebecca. So sorry, I came in a bit late and I didn't hear the part about which you probably mentioned about the statistical significance versus a clinical significance. Can you just give us a little bit of an insight on how can you calculate that clinical significance? What should we do? Is it previous literature? Is it your experience?
Yeah, good question. Thanks, Rick. So I think it's our statistical significance, right? We can say, what's the numbers in front of us? But in clinical significance, right, I might see that, for example, in anemia, the prevalence, 8% may or may not be significant. But if I think about it, if I take it back out into clinic, if I see how many extra women might I need to treat for this to be beneficial, and we can look at previous literature, what's been before, we can also take into account other aspects. So, more of our implementation or our feasibility of actually how do these women feel it went, and would that be a big difference if a woman came into the clinic and got treated with anemia or not? Would it be beneficial to them? So it takes into clinician knowledge, previous literature, everything that we've sort of come across. Because sometimes if it's significant just by a p-value, doesn't mean that you should necessarily go and change all the guidelines if it's not going to really change practice or have an effect on those who we're trying to do the study for in the field. Yeah, so a lot of ours is if we don't know. So for example, when we did this revamp trial, we didn't know what that prevalence or percentage difference might be. So some of the numbers that we can calculate, are our number needed to treat or our number needed to harm. And so if we were to treat, for example, 100 women, or how many would you need to treat to see a benefit or see an approval? So ideally, we look for the number needed to treat. If you're looking for a safety or other element, it might be the number needed that you would have to treat before you caused harm. If we really need to, we can dive down and do other analyses like, how sensitive or how specific it is, or our positive predictive values, our negative predictive values in our 2x2 table to see how important that is. But we can go through, I didn't touch on number needed to treat today, but there are numbers that we can look into to derive that importance as well.
Do we have any questions online in the chat?
Thank you, Rebecca, for the talk. I know you've mentioned about the importance of pre-designed statistical analysis plan. I just got a question about how flexible it is to make adjustment to that statistical analysis plan, but also to ensure scientific rigors after you've sampled your data and realize you might need to make some tweaks about it.
Yeah, no, excellent question. So we try and predefine as much as we can. But we sign this off and we lock it before database lock, but inevitably there are some things that come up, like you don't have a crystal ball, you can't plan for everything. Yeah. So we do always present in the supplements of a paper as well, and we note and document any changes that happened after that lock. And so that's where we can be a little bit flexible with what we've seen in our data that we didn't know existed before we made this plan. So there is some flexibility, but we need to just be completely transparent. So when we write the statistical analysis, we're like, this is what we're going to do and this is what's here. And we're not going to deviate that because we saw some exciting p-value that we've the causal questions here chased along the way. But there obviously are things that you can't anticipate. So we do have that flexibility to say, hey, this is what we saw and this is what we changed and why we did it. But it's just about that process of being completely transparent in what you planned and what you did and why that changed throughout the time.
Thank you for your response.
Hi, so I've just got a question regarding missing values and normalization. So when should I do my normalization, before or after imputation?
So we tend to do great question. I didn't touch on missing data at all here today. It's a very good point. So we tend to do our analyses in a clinical trial, so as is the data that's there. And then we do our multiple imputation, and then we see if our effect sizes sort of changed after there. So again, it's kind of depends on the research question itself and what you are trying to answer in the context of your study. So there's no one size fits all, unfortunately, and there is different ways to impute and different ways to normalize. But it's kind of done, if we've pre-planned it in our analysis plan and we know what to do, we can follow those steps. So unfortunately, I can't give you a how to, but we can help guide you on where to go and look and what that would mean for your question in particular.
Okay, yeah, thank you.
Any other questions from the audience, online or in the room? Okay, then let's thank Rebecca again for today's presentation.